Welcome to the Deep Dive, the only place where we really take the densest, most critical information, strip away the noise, and turn it into true professional mastery. We're not here for just a quick summary. We're here to understand concepts like the elite professionals in the field. Today, we are really immersing ourselves in the pharmacology of the heart. Specifically, we're focusing on a molecule with, well, a history stretching back centuries, cardiac glycosides, and the main example we use is digoxin. We're talking about an extract that comes from the humble foxglove plant at digitalis, which was, for generations, pretty much the only effective weapon against dropsy, or what we now know as severe heart failure edema.
Yeah, that history is fascinating, absolutely. But our goal here, for you listening, is really mastery of two interconnected subjects. First, the incredibly intense and pretty complex molecular mechanics of digoxin itself. And second, understanding that revolutionary paradigm shift in treating heart failure that, really took hold around the 1980s. This shift was the realization that we had to move beyond just sort of strengthening the pump.
Yeah.
We needed to start aggressively fighting the underlying disease progression itself.
And that brings us, I think, to the core contradiction we really need to resolve today. Digoxin, it was the cornerstone, right? The main treatment until, the late 20th century. But now, it's strictly a secondary therapy, an add-on.
Exactly.
So we need to dissect exactly why this demotion happened. And that means truly mastering the drug's mechanism, its inherent dangers, which are significant, and the evolved understanding of heart failure, seeing it as this neurohumoral remodeling disease, not just, a plumbing problem.
Precisely. Because when you truly understand the mechanism of digoxin, you understand that its toxic effects are, they're basically inseparable from its therapeutic benefits. They come from the same place. That incredibly narrow safety margin and the fact that it completely fails to modify the disease course, that pushed it aside the moment we found drugs that could actually increase survival. Right. So let's start right at the beginning, almost 250 years ago.
Okay, origins. We have to talk about William Withering-Wright, the physician in Birmingham. His classic monograph, published way back in 1785, documented using foxglove extract to manage that, horrific fluid retention we now call advanced heart failure.
Withering's work is absolutely foundational, no question. But it's important, to appreciate how the clinical understanding evolved over time. He accurately observed the diuresis, the reduction in edema that was the beneficial effect he saw.
Right, the dropsy going away.
Exactly. He actually attributed it primarily to the drug acting on the kidneys. He thought the benefit was purely renal. It wasn't really until the early 20th century, with researchers like Cushney and Mackenzie, that it was definitively shown that the life-saving action, was actually a direct effect on myocardial contractility.
So boosting the heart muscle itself.
Yes. And that led to its established use in congestive heart failure, or CHF.
Okay. So when we use the professional term cardiac glycoside, what does that chemical term really mean? And where do these compounds actually come from naturally?
Okay, so cardiac glycosides are a class of drugs. They're glycosidic drugs, meaning they have sugar parts, and they're specifically defined by their cardiac inotropic properties.
Inotropic meaning?
Meaning the ability to increase the force of contraction. They're found in quite a few plant sources. Digitalis lanata gives us digoxin, which is really the only one we use clinically now. But historically, digitoxin from Digitalis purpurea was also used.
Right.
And for a bit of wild trivia, similar compounds known as bufatoxins are naturally found in the skin of certain toads.
Toads, wow. Okay, that journey from foxglove to toad skin really highlights the diverse natural pharmacology out there. Let's try and nail down the chemistry a bit, because to master this drug, we need to understand its structure. What are the two core parts?
Right, good question. They're defined by two essential components. First, you have the aglycone, or sometimes called the genin. That's the non-sugar part. And it's responsible for the fundamental pharmacological action.
Okay, the business end.
Kind of, yeah. And second, you have one or more sugar moieties, things like glucose or digitoxose, attached to that aglycone. These sugars, they mainly influence the drug's solubility, its kinetics, how it moves around the body, and its distribution into tissues.
And the aglycone itself, the name sounds pretty dense. Cyclopentanoperhydrophenanthrene.
Chuckles slightly. That's a mouthful. That describes the core steroid nucleus, the cyclopentanoperhydrophenanthrene ring. It's that bulky four-ring structure common to all steroids. But critically, attached to the steroid part is a 5 or 6-membered unsaturated lactone ring.
Okay.
And it's the specific shape and chemical properties of this steroid nucleus combined with that lactone ring that allows it to bind so precisely and have its potent cardiac action.
Got it. So moving to the overall pharmacological profile, digoxin is our prototype. Beyond just increasing contraction force, what are the other key effects that tell us this is doing more than just, squeezing the muscle harder?
Well, all cardiac glycosides share qualitatively similar actions, and digoxin is our model. The primary effect, yes, is that dose-dependent increase in myocardial contractility. But systemically, we see really critical electrophysiological properties, how it affects the heart's electrical system. And it has profound vagomimetic action. It basically acts like you've stimulated the vagus nerve, which influences heart rate and conduction. Plus, it produces powerful reflex effects because of the hemodynamics, the blood flow changes, and there are even direct effects on the central nervous system that modify sympathetic nerve activity.
So it's really a full-spectrum neurohumoral agent in a way. But its initial clinical use, the reason Withering used it, hinges on that positive inotropic effect. And you mentioned it's especially pronounced in the failing heart.
Precisely. In CHF, the goal is often to shorten systole, the contraction period, and prolong diastole, the filling time. This allows the heart to work more efficiently. Digoxin helps achieve that, which kind of leads us perfectly into the next level of mastery, understanding the deep mechanics of how it actually does this.
Okay, let's transition into the cellular mechanism. We need to understand the mechanical consequence first. In a failing heart, as resistance to outflow the afterload or impedance goes up, the stroke output tends to plummet, right?
Yeah.
How does digoxin change that relationship?
That's a key point. A normal, healthy heart is pretty resilient. It can cope with increased afterload by generating more tension, more force. The failing heart, however, lacks this reserve capacity.
Right.
Its ability to compensate is severely compromised. So if resistance rises, stroke volume just drops off a cliff. Digitalization, using digoxin, essentially restores some of that lost capacity. By forcing the heart muscle to contract more forcefully, the dilated failing ventricle can achieve more complete emptying with each beat.
Okay, so it pushes more blood out despite the resistance.
Exactly. This dramatically increases cardiac output, and critically, it reduces that elevated end diastolic volume, the amount of blood left in the ventricle before it contracts.
And that reduction in end diastolic volume, that's often overlooked, isn't it?
Yeah.
But it's key to breaking that vicious cycle of dilation and worsening wall tension, the whole law of Laplace thing.
Absolutely. Less stretch means the heart works more efficiently. Now, let's dive down to the molecular level. This is where true professional mastery comes in. What is the absolute first step in digoxin's mechanism?
Okay.
Step 1 is highly selective inhibition. Digoxin finds and binds to the extracellular face of the membrane-associated Na plus K plus ATPase on the heart muscle fibers. This enzyme, the sodium-potassium pump, is the critical cation pump. It uses ATP energy to constantly pump 3 sodium ions out of the cell for every 2 potassium ions it pumps in. Digoxin jams this pump, inhibiting it in a dose-dependent way.
Okay, so it blocks the sodium pump on the outside. When you slow or inhibit that pump, the balance inside the cell must start to shift. What's the immediate consequence inside the cell?
Well, since sodium isn't being kicked out as efficiently, there's a gradual, progressive accumulation of sodium inside the cell. The cytosolic Na plus concentration starts to creep up. Now, here's a detail that really marks mastery. The size of this change is actually very small.
Oh, really?
Yeah, we're talking about raising the intracellular concentration from a baseline of maybe 8, 10 millimolar mmM to perhaps only 1 or 1.5 millimeter higher. A tiny increase.
Wow, that seems minuscule. How can such a tiny change in sodium lead to that big jump in contraction force? What's the link to calcium?
This is the crux of it. That small rise in cytosolic Na plus fundamentally reduces the transmembrane Na plus gradient. Think of that gradient like the steepness of a hill. A steep hill, the normal gradient, makes it easy for the cell to use that downhill roll of sodium coming in to power other things, specifically kicking calcium out.
Okay.
When digoxin inhibits the pump, the intracellular Na plus rises slightly, flattening that hill. This gradient is the driving force for another crucial transporter, the 3Na plus 1Ca2 plus exchange transporter, or NCX antiporter.
So the NCX normally uses that strong sodium gradient, the steep hill, to push calcium out of the cell. But if the gradient is weaker, if the hill is flatter.
Exactly. The NCX can't work as effectively. It relies on that steep sodium gradient to provide the energy to extrude Ca2 plus 1. With a flatter gradient, the NCX slows down. Calcium isn't pushed out as efficiently, so it starts to be retained within the cytosol. This is the molecular pivot point.
Okay, so calcium stays inside longer. What happens to it then?
This retained excess Ca2+ is then immediately and efficiently souped up and sequestered by the sarcoplasmic reticulum, SR, the cell's internal calcium storehouse. It does this via an enzyme called SERCA2, sarcoplasmic endoplasmic reticular calcium ATPase 2. This action progressively loads the SR with massive amounts of stored calcium.
So the SR becomes like a supercharged calcium battery. The stage is set. When the next electrical signal, the action potential, arrives and lets in that little bit of trigger calcium through the L-type channels, what happens now with this overloaded SR?
That tiny trigger influx of Ca2+ now hits this supercharged reservoir in the SR. It causes a much, much larger release of calcium from the SR, flooding out via the ryanodine receptor RYR2 channels. The resulting calcium transient, the spike in cytosolic calcium, is dramatically augmented.
Right.
This leads to a stronger interaction between calcium and troponin C on the muscle filaments, and thus a markedly stronger positive inotropic contraction. That whole cascade explains why a tiny initial shift in sodium yields such a huge change in contractility.
And this complexity, this multi-step process, it explains why the therapeutic effect isn't instant, right? Why does it take hours to fully develop, even if you give it intravenously?
Precisely, because the whole thing relies on the gradual inhibition of the NA plus K plus ATPase pump, and then the slow cumulative loading of the SR with calcium. It's a kinetic constraint. Even if we flood the plasma with digoxin the fourth, the maximal inotropic effect won't really manifest for several hours. This is a critical difference from the rapid, short-acting 5E inotropes we use in acute emergencies, like the butamine or milrinone. They work via CAMP and have effect measured in minutes, not hours.
Makes sense.
Yeah.
Let's pivot now to the electrical consequences. This is where the danger starts to creep in. How does digoxin fundamentally alter the action potential, the electrical signature of the heart cell?
Well, the changes start right at the baseline, the resting membrane potential, RMP. It becomes progressively less negative, more depolarized as the dose increases. This directly impairs the rate of phase zero depolarization, that rapid upstroke of the action potential.
Yep.
And that slowing of the upstroke means slower conduction velocity. This effect is most pronounced in the specialized conduction tissues, the AV node and the bundle of His.
This slowed conduction of the AV node is actually therapeutically useful sometimes, like in atrial fibrillation, right? But the electrical effects also manifest the drug's inherent danger you mentioned, enhanced automaticity.
Exactly. That's the toxicity really coming to the fore. In the Purkinje fibers, PFs, these are cells lower down in the ventricles that can sometimes act as pacemakers. Digoxin increases the slope of phase 4 depolarization. That's the gradual drift back towards the firing threshold.
Okay.
By increasing that slope, it enhances ectopic automaticity. It makes these normally quiet Purkinje fibers more likely to fire off on their own, generating extra beats or extra systoles. At highly toxic concentrations, this can lead to complex coupled beats caused by abnormal oscillations in the resting potential called delayed after depolarizations, DADs.
Nasty stuff. But you also mentioned it causes therapeutic slowing in the conduction system, the SA and AV nodes, through a different mechanism.
Correct. At therapeutic concentrations, digoxin has that potent vagomimetic action we talked about. It mimics the effects of the vagus nerve. This actually causes hyperpolarization, making the cells in the SA and AV nodes less likely to fire spontaneously. It reduces their phase 4 slope.
Oh, okay.
So it decreases their automaticity and helps slow down the ventricular rate, which is exactly what you want in conditions like rapid atrial fibrillation. It's a really delicate, dose-dependent, and sometimes contradictory balancing act electrically.
Okay, let's clarify the effect on the effective refractory periods, ERP. This is essential for understanding the risk of arrhythmias. How does digoxin affect the ERP in different parts of the heart?
Yeah, this is complex because the drug acts differently in different tissues. In the atrium, the ERP is actually decreased by the vagal action, but increased by the direct action on the muscle cells. So the overall outcome there can be a bit mixed and heterogeneous.
Okay.
However, in the AV node and the bundle of His, the ERP is unequivocally increased. This is due to that combination of vagal effects, direct vagomimetic action, and maybe some antiadrenergic effects too. This increase in ERP is key to its use in controlling the heart rate in AFib. It blocks more of the rapid atrial impulses from getting through.
Makes sense.
But paradoxically, down in the ventricle, the ERP is actually abbreviated or shortened by the direct action of the drug. So you have this dangerous situation. Increased refractory period in the AV node blocking conduction, but a shortened refractory period in the ventricle, making it more excitable and prone to re-entrant arrhythmias.
That sounds like a recipe for trouble.
Yeah.
Finally, on the electrical side, What are the classic ECG signs? What helps you distinguish a therapeutic ECG effect from a potentially toxic one?
Right, good question. A therapeutic ECG often shows things like decreased T-wave amplitude or even T-wave inversion. This just reflects changes in repolarization. You'll definitely see an increased PR interval, which directly reflects that slowed AV conduction we discussed. And you might see a shortening of the QT interval, which corresponds to that accelerated ventricular repolarization, the shortened systole. Now, once doses become high or toxic, the ECG changes become more sinister. Look for pronounced depression of the ST segment, which indicates interference with repolarization. You might see signs of profound AV block, like dropped beats or very slow rates, and critically, the appearance of ectopic arrhythmias, things like premature ventricular contractions, PVCs, especially if they occur in patterns like bigeminy.
Okay, let's shift focus a bit away from the heart itself to the systemic effects. What does digoxin do to blood vessels? Does it raise or lower systemic vascular resistance overall?
That's interesting. The direct action of digoxin on blood vessel smooth muscle is actually a weak vasoconstrictor. So in theory, in a healthy person, it might slightly raise peripheral resistance. However, in the patient with congestive heart failure, the situation is different. Remember, these patients often have high sympathetic tone causing generalized vasoconstriction. When digoxin improves cardiac output and circulation, this reflex sympathetic overactivity gets withdrawn.
So the indirect effect wins out in CHF.
Exactly. The net effect in a failing patient is often a beneficial decrease in peripheral resistance. Overall, there isn't usually a major impact on blood pressure itself, although the pulse pressure, the difference between systolic and diastolic, might increase a bit due to the increased stroke volume. And it doesn't seem to have a significant effect on coronary circulation either.
And the kidney effect. Let's circle back to Withering's original idea.
Right. Digoxin does cause prompt diuresis, meaning increased urine output. But, and this is crucial for mastery, this only occurs in CHF patients. It's entirely secondary. It's due to the improved systemic circulation and the resulting increase in renal perfusion pressure, better blood flow to the kidneys. By helping the kidneys excrete the retained salt and water, it helps resolve the edema. But importantly, digoxin causes absolutely zero diuresis in normal individuals or in people who have edema from other causes, like kidney or liver disease. It's purely a consequence of fixing the circulation in heart failure.
That's a really key distinction. Now, high-level mastery requires a deep understanding of the drug's journey through the body, its pharmacokinetics. This seems central to its cumulative risk profile.
Absolutely. The kinetics really explain why it has such a narrow therapeutic window. Digoxin actually has pretty good oral bioavailability, usually somewhere between 60 to 80%, although taking it with food can delay absorption a bit. But the really striking thing is its volume of distribution, VD. It's enormous, typically 6 to 8 liters per kilogram. This means the drug doesn't stay mainly in the blood. It distributes widely and concentrates heavily in peripheral tissues, especially muscle, and critically, in the heart muscle itself, where concentrations can be 20 times higher than what you measure in the plasma.
Wow, 20 times higher in the heart. And the elimination phase, that's notoriously slow, right?
Incredibly slow. Its plasma half-life, T, is approximately 40 hours. This long half-life defines it as a classic cumulative drug. A dose given today is still significantly present 2, 3, even 4 days later.
Right.
And since elimination is predominantly via the kidneys, it's excreted mostly unchanged in the urine. The rate of elimination is directly parallel to the patient's creatinine clearance, their kidney function. This means you have to be extremely cautious and adjust doses significantly in patients with renal impairment or in the elderly who often have reduced kidney function.
And that 40-hour half-life means it takes a long time to reach a steady level.
Exactly. To achieve a steady state concentration in the body and get the full therapeutic effect, it takes about 4 to 5 half-lives. So with a 40-hour half-life, you're looking at 160, 200 hours, or roughly 6 to 7 days, when you're just using standard daily maintenance doses.
This inherent slowness, the tissue concentration, and the mechanism itself, it all seems to culminate in this perilously low margin of safety.
It really does. The therapeutic index, the ratio between the toxic dose and the therapeutic dose is alarmingly low, maybe only 1.5 to 3. The professional target therapeutic concentration in the plasma is very narrow, typically 0.5 to 1.4 nanograms per milliliter in GMLO. Toxicity commonly starts to rear its head above 2 NEMLO. The sobering reality is that historically, maybe up to 25%, a quarter of patients on chronic digoxin therapy experience some form of toxicity.
A quarter. That's huge. Okay, let's categorize the symptoms of toxicity. What are the key early warning signs that should trigger immediate alarm bells for anyone managing these patients?
The extracardiac symptoms, the ones outside the heart, are often the crucial early warnings. They tend to precede the serious cardiac toxicity in about 2/3 of patients.
Okay, like what?
Things like anorexia, loss of appetite, nausea, and vomiting. These are caused partly by direct irritation of the stomach, but also significantly by activation of the chemoreceptor trigger zone, CTZ, in the brainstem. Other nonspecific but really important warnings include fatigue, muscle weakness, mental confusion, disorientation, and those characteristic visual disturbances patients might describe seeing yellow or green halos around lights or blurred vision.
Yellow-green halos, right. And the cardiac toxicity itself sounds like a pharmacological nightmare. You said almost every possible conduction defect or arrhythmia can manifest.
Pretty much, yeah. It can present as profound sinus bradycardia, a very slow heart rate. It can cause partial or complete AV block, where the signals from the atria don't get through to the ventricles properly. Or it can cause increased automaticity leading to those ectopic beats we talked about. A really classic, almost hallmark sign is pulsus bigeminis, where every normal heartbeat is followed by a premature ventricular contraction, PVC.
Okay.
And of course, it can lead to life-threatening ventricular tachycardia or even ventricular fibrillation, which is the immediate threat to life. The real tragedy, the core issue, is that these toxic effects stem directly from the same fundamental mechanism as the therapeutic effect, that excessive myocardial calcium loading. The harmful and the beneficial properties are mechanistically inseparable.
Right, that's the inherent problem.
Here.
Okay, imagine a patient you strongly suspect digoxin toxicity. Walk us through the non-negotiable management strategy. What absolutely has to happen first?
First and foremost, stop all further doses immediately. That sounds obvious, but it's critical. Then you have to address the arrhythmias and the electrolyte status. For tachyarrhythmias, fast rhythms, especially ventricular ones, particularly in patients on chronic therapy where toxicity might be compounded by diuretic-induced hypokalemia, low potassium, we seriously consider infusing potassium chloride, KCl.
Why potassium?
Because high extracellular potassium actually helps reverse the toxicity in a couple of ways. It competes with digoxin for binding sites on the NAT plus K plus ATPase, reducing the drug's effect. And it also tends to antagonize or counteract that enhanced automaticity caused by the drug.
But the decision to give K plus A, that's fraught with danger too, right?
Yep.
When is it absolutely contraindicated?
Absolutely. Giving potassium is strictly contraindicated if the patient already shows signs of high-degree AV block on the ECG. In that situation, raising potassium levels further can rapidly precipitate complete heart block and even a systole.
Yeah.
Exactly. Furthermore, if the toxicity is due to an acute overdose, like someone taking a whole bottle of pills, plasma K plus levels might actually already be dangerously high due to massive cell damage releasing intracellular potassium. Giving more K plus then would be incredibly dangerous. You absolutely must measure the serum K plus level first to guide this therapy.
Okay, crucial point. What about specifically managing life-threatening ventricular arrhythmias? You want something that works without making any potential AV block worse.
Lidocaine is generally the drug of choice here. It's quite effective at suppressing that ectopic automaticity in the ventricles without significantly accentuating AV conduction defects. Conversely, other antiarrhythmics like quinidine, procainamide, or propafenone are generally contraindicated.
Why is that?
Because they can actually increase digoxin plasma levels by interfering with its metabolism or excretion, and they also tend to depress AV conduction further, which could worsen any existing block. For severe AV block or profound bradycardia, the treatment is usually temporary cardiac pacing, or sometimes atropine can be tried.
And what's the absolute rule about using electrical cardioversion, a DC shock?
This is a professional absolute. Cardioversion by DC shock is considered contraindicated in the digitalis intoxicated heart. The electrical shock can unmask or severely exacerbate the underlying conduction defects, often leading to refractory ventricular fibrillation, which is very difficult to treat. You have to stabilize the toxicity first.
Right. Fortunately, we do have a highly specific antidote now, don't we?
Yes, thankfully. We have digoxin-specific antibody fragments, or Fab fragments. They're marketed under names like Digibind or Digifab. These antibodies physically bind to the digoxin molecules in the blood and tissues, effectively neutralizing them and allowing them to be rapidly excreted by the kidneys. They are highly effective in reversing life-threatening cardiotoxicity.
That's a lifesaver.
Yeah.
Finally, we absolutely have to mention drug interactions. Which common cardiovascular drugs significantly amplify the risk of digoxin toxicity?
Yeah, this is critical for safe prescribing. The most obvious risk factor, as we mentioned, is hypokalemia, often induced by loop diuretics like furosemide or thiazides. Low potassium sensitizes the heart to digoxin's effects.
Okay.
But several other major cardiovascular drugs can significantly increase digoxin plasma concentrations, often by inhibiting its elimination. Key culprits include quinidine, verapamil, diltiazem, captopril, and especially amiodarone.
Amiodarone is a big one.
Huge interaction potential. Many of these drugs inhibit P-glycoprotein, which is an efflux transporter pump involved in clearing digoxin from the body. If you start one of these interacting drugs in a patient already on digoxin and you fail to proactively reduce the digoxin dose, you can precipitate toxicity very quickly. Constant vigilance is required.
Okay. The detailed mechanics of digoxin have really shown its power, but also its significant limitations and dangers. Now let's pivot to the disease itself, heart failure. We know it's broadly defined as the heart's inability to pump enough blood to meet the body's demands, or only being able to do so by dangerously elevating the filling pressures. Understanding this pathophysiology was key to the paradigm shift in treatment. Let's start by defining the two primary functional types of heart failure.
Right. Heart failure isn't one single entity, it's a progressive clinical syndrome. The first major distinction we make is systolic dysfunction, which we now often call heart failure with reduced ejection fraction, or HFrEF. This is defined by an ejection fraction, the percentage of blood pumped out with each beat typically less than 40%.
So the pump is weak.
Exactly.
Right.
The primary failure here is deficient pumping, poor contractility. As a consequence, the ventricles often dilate, they get bigger. This is mechanically disastrous because of the law of Laplace, which basically says that the tension the heart wall has to generate is proportional to the pressure inside times the radius.
Bigger radius, more tension needed.
Right. The dilation exponentially worsens the mechanical inefficiency, making it harder for the already weak heart to pump. The most important underlying causes for HFrEF are things like coronary artery disease leading to myocardial infarction, heart attack, and the resultant loss of functional heart muscle.
Okay. And the other side of the coin, where the pump seems okay on the ejection fraction test, but the patient still has heart failure.
That's diastolic dysfunction, now more commonly termed heart failure with preserved ejection fraction, or HFpEF. Here, the problem isn't necessarily weak contraction. Instead, the ventricular walls are often thickened and stiff, typically due to long-standing high blood pressure causing left ventricular hypertrophy, LVH.
So they can't relax properly.
Precisely. The stiff ventricle can't relax and fill adequately during diastole, the filling phase. So even though the percentage ejected EF might look normal or near normal, the actual stroke volume, the amount of blood pumped out, is reduced because the heart simply couldn't take in enough blood in the first place.
Got it. Now, the major breakthrough in understanding, the one that really changed treatment, was the realization that heart failure, especially HFrEF, isn't just a simple problem of low contractility. It's actually a vicious, self-perpetuating hormonal disease driven largely by the body's own attempts to compensate.
Exactly. That was the huge conceptual leap. Reduced cardiac output, CO, initially triggers what seem like helpful compensatory mechanisms, but chronically these mechanisms become incredibly destructive. First, you have the Frank-Starling mechanism.
Right. Stretching the heart makes it contract harder.
Initially, yes. Increasing the filling pressure stretches the muscle fibers, which helps maintain stroke volume for a while. But the inevitable trade-off is the symptoms of congestion fluid backing up into the lungs, causing pulmonary edema, and fluid accumulating in the periphery, causing edema in the legs and abdomen.
Okay. And then comes the really lethal combination, neurohumoral activation. Let's focus on the two main culprits here.
The first is the augmentation of sympathetic nervous system tone. When the brain senses reduced CO, it immediately ramps up sympathetic stimulation. This does help acutely by increasing heart rate and contractility and causing vasoconstriction to maintain blood pressure.
But long-term.
Long-term, chronic, pathological sympathetic overactivity is profoundly toxic to the heart. It directly promotes the death of cardiac muscle cells apoptosis. It encourages fibrosis or scarring within the heart muscle, and it significantly contributes to the risk of developing dangerous, potentially fatal arrhythmias. It actively drives the disease progression.
Okay, so that's one major destructive pathway. What's the second big one?
The second major culprit is the renin-angiotensin system, RAS, or more accurately, the renin-angiotensin-aldosterone system, RAAS. Its activation is absolutely pivotal in heart failure. The drop in blood pressure and renal perfusion pressure triggers the kidneys to release renin.
And renin kicks off the cascade.
Right. Renin leads to the production of angiotensin II, ANG2. ANG2 is a potent vasoconstrictor, which further increases the workload on the failing heart, increases afterload. But the chronic exposure to ANG2 is the real problem. ANG2 acts directly on the heart muscle and blood vessels, leading to pathological changes like left ventricular hypertrophy, detrimental myocardial remodeling, changes in size, shape, and composition, and widespread fibrosis. So the RAS is destructive both hemodynamically, by constricting vessels, and structurally, by damaging the heart muscle itself.
And within that system, aldosterone itself has been increasingly recognized as playing a significant independent role beyond just sodium and water retention, right?
Absolutely. Even if ANG2 levels are partially blocked by drugs, aldosterone production can continue, sometimes through aldosterone escape. Aldosterone, besides promoting sodium retention and potassium loss, which increases arrhythmia risk, directly stimulates fibroblast proliferation in the heart.
Fibroblasts mate.
Collagen and fibrous tissue. So aldosterone actively contributes to the scarring and stiffening, the adverse structural remodeling, which is a major driver of chronic heart failure progression. Now, the body does try to fight back a bit by releasing counter-regulatory peptides, things like atrial natriuretic peptide, ANP, and brain natriuretic peptide, BNP, usually in response to the stretching of the heart chambers. These peptides try to oppose the vasoconstriction and sodium retention.
But they get overwhelmed.
In progressive heart failure, yes, this beneficial system is usually overwhelmed by the relentless drive from the sympathetic system and the RAAS.
This whole understanding heart failure as a neurohumoral remodeling disease completely redefined the therapeutic goals, didn't it? Before the 1980s, what was the primary aim?
Before this understanding really took hold, say pre-1980s, the goal of therapy, goal A if you like, was primarily focused on relief of congestive symptoms and low-output symptoms. The main tools were digoxin, to try and boost the pump, and diuretics, to get rid of the fluid.
But they didn't fix the underlying problem.
Exactly. They made patients feel better, certainly, but they did absolutely nothing to modify the underlying disease course or improve long-term survival. They were just treating the symptoms.
So the modern goal, goal B, shifted dramatically.
The modern goal, goal B, is fundamentally different. It's focused on arresting or reversing the progression of the disease itself and prolonging survival. This requires using agents that specifically target and antagonize those maladaptive neurohumoral drivers, the ACE inhibitors, the angiotensin receptor blockers, ARBs, the beta blockers, and the aldosterone antagonists. This shift is what completely redefined the role of drugs like digoxin.
Okay, so if RAS activation is, as you said, a pivotal driver, maybe even the sheet anchor of the pathology in HFR-EF, then it makes sense that the RAS inhibitors, the ACE inhibitors, and the ARBs became the modern sheet anchor of therapy. Let's delve into their specific benefits, especially regarding survival.
They are absolutely critical, foundational really. ACE inhibitors, like enalapril, lisinopril, and ARBs, like losartan, valsartan, provide symptomatic relief, partly through vasodilation, which reduces the workload on the heart. But much more importantly, they are disease-modifying.
How so?
By reducing the levels or blocking the effects of angiotensin II, they directly combat those pathological processes we just discussed. They help retard ventricular hypertrophy, they fight against myocyte apoptosis, cell death, and they limit the detrimental fibrosis and remodeling. Their efficacy is rock solid, established across all classes of HFR-EF, from mild NYHA Class 1 to severe NYHA Class 2. Landmark trials consistently showed they provide an overall reduction in mortality of around 20% or more.
A 20% mortality reduction? That's huge, and something digoxin just couldn't do.
Exactly. This is a true prognostic benefit, changing the natural history of the disease. Digoxin simply cannot match that.
Now, there's a subtle but important mechanistic difference between ACE inhibitors and ARBs that professionals really need to grasp, right?
Yes, there is. ACE inhibitors work by blocking angiotensin-converting enzyme, the enzyme that converts angiotensin I to the active angiotensin II. But ACE also happens to be the enzyme that breaks down bradykinin, a type of kinin.
Right.
So when you inhibit ACE, you not only reduce angiotensin production, but you also get an increase in bradykinin levels. And increased kinins are thought to be beneficial because they can stimulate the local production of cardioprotective substances like nitric oxide, NO, and prostaglandins, PGs, which which cause vasodilation and may have other protective effects.
And ARBs don't do that.
Correct. ARBs work differently. They don't block the enzyme. They directly block angiotensin II from binding to its main receptor, the AT1 receptor. This provides potentially a more complete blockade of ANG-T's actions at that receptor, but because they bypass the enzyme, they do not lead to that accumulation of beneficial tissue bradykinin. Whether this difference is clinically significant is still debated sometimes, but it's a key pharmacological distinction.
Got it. Okay, next up, the beta-adrenergic blockers. This was a huge paradigm shift too, wasn't it? The initial caution around using these drugs in heart failure was immense because their immediate acute action is negative inotropic. They actually make the heart pump weaker initially, yet they provide a proven massive survival benefit. Why the paradox?
It's one of the greatest sort of counterintuitive stories in modern cardiology. The benefit doesn't come from their acute effect, but from antagonizing the long-term pathological effects of that chronic sympathetic overactivity we talked about.
The apoptosis, the remodeling.
Exactly. By blocking the constant bombardment of beta receptors on the heart by norepinephrine, drugs like metoprolol succinate, the long-acting SR form, bisoprolol carvedilol, which also has some alpha-blocking effects, and nebivolol fundamentally interrupt those destructive pathways. They reduce myocyte death, they help reverse or slow down adverse remodeling, and they significantly reduce the propensity for those sinister, fatal arrhythmias. Over time, they change the cellular landscape for the better.
But that initial negative inotropic effect is real and dangerous if not managed properly.
Absolutely. Which is why they are strictly contraindicated in patients who are acutely decompensated, who are in cardiogenic shock or crashing. You cannot start a beta blocker then.
So the dosing strategy is absolutely critical for safety and success.
It is non-negotiable. Beta blocker therapy in heart failure must be initiated at a very low dose. We're often talking an eighth or even a 16th of the eventual target dose.
Oh, tiny doses.
Yes, and then it has to be titrated upwards extremely slowly, often doubling the dose only every 2 to 4 weeks or even longer, carefully monitoring the patient at each step to ensure they remain stable. This painstaking process gives the heart time to adapt to the reduced sympathetic drive and allows the long-term beneficial anti-remodeling effects to emerge without causing acute worsening. Landmark trials like MERIT-HF, metoprolol, Cibistic bisoprolol, and Copernicus carvedilol definitively prove their indispensable role in reducing mortality in HF-REF.
Incredible results, but requires patience. Then we add the third leg of the neurohumoral blockade stool, aldosterone antagonist, addressing that secondary remodeling pathway you mentioned.
Right. Even when patients are on an ACE inhibitor or an ARB, aldosterone production can sometimes persist or escape blockade. And as we discussed, aldosterone itself contributes substantially to fibrosis, inflammation, and endothelial dysfunction, as well as promoting dangerous hypokalemia, which increases arrhythmia risk.
So drugs like spironolactone.
Exactly. Spironolactone, or the more selective agent eplerenone. The RALIS trial with spironolactone and the EPHESIS trial with eplerenone post-MI demonstrated clear mortality and anti-remodeling benefits when these drugs were added, usually in low doses, to the standard regimen of an ACI or ARB and a beta blocker, particularly in patients with moderate to severe HF-REF like NYHA class 3-4 or post-MI with LV dysfunction.
And you mentioned low doses.
Yes. Importantly, the doses used for these heart failure benefits, typically 12.5 to 25 milligram, but maybe up to 50 milligram is tolerated, are generally lower than the doses used for diuresis. The primary goal here is blocking the harmful hormonal effects of aldosterone on remodeling, not necessarily causing significant fluid loss. Using lower doses also helps minimize the main risk, which is hyperkalemia, high potassium, especially when used with ACE-IRBs, which also tend to raise potassium. Eplerenone is often favored now because it's more selective for the mineralocorticoid receptor and avoids the side effect of gynecomastia, breast enlargement in men, that can occur with spironolactone.
Good point. Now, diuretics drugs like furosemide, loop diuretic, and thiazides, almost every symptomatic CHF patient ends up on one. But you stress they carry a severe limitation in terms of the disease itself.
Yes, their role is purely 100% symptomatic relief. They're absolutely crucial for managing the symptoms of congestion because they rapidly decrease preload, the volume load on the heart, by promoting salt and water excretion. They remove edema fluid from the lungs and periphery, which makes patients breathe easier and feel much better. 4-V furosemide is essential for providing rapid relief in acute decompensated heart failure. But, and this is the key limitation for mastery, they have no proven prognostic benefit, they do not slow disease progression, they do not reverse remodeling, and they do not improve long-term survival. They just manage the fluid overload. In fact, chronic aggressive use can sometimes be detrimental by causing electrolyte depletion, especially potassium and magnesium, and by further activating the RAS due to volume depletion. However, they remain the primary drugs for managing the symptoms of congestion, especially in patients with HFpEF, diastolic dysfunction, where neurohormonal blockers haven't shown the same clear mortality benefits.
Okay, symptomatic relief only. What about vasodilators? Where do they fit into the long-term picture today, beyond acute situations?
Vasodilators are generally reserved for acute management or specific situations. We classify them based on whether they primarily dilate veins, like nitrates, which reduce preload, arterioles, like hydralazine, which reduces afterload, or both, like sodium nitroprusside, used IV for very rapid and potent reduction of both preload and afterload in emergencies.
Any role in chronic therapy?
Long-term utility as single agents is pretty limited. However, there's one important exception: the specific combination of hydralazine plus isosorbide denitrate. This fixed-dose combination was studied in the AHEFT trial and showed a significant survival benefit, specifically in African American patients with HFrEF who were already on standard therapy. It's also considered a valuable option for patients who cannot tolerate ACE inhibitors or ARBs, often due to worsening renal function or hyperkalemia.
Interesting niche there. Okay, now let's finally bring it back and integrate our original focus molecule, digoxin. After all this compelling evidence supporting the neurohumoral blockers, what is its precise current role in the modern management of heart failure?
Digoxin's role is now strictly adjunctive and quite limited. It is definitely not a first-line drug for HFrEF anymore. It might be considered for adding on, primarily for symptomatic relief, in patients who remain significantly symptomatic, e.g. NYHA class 2-3, despite being on optimal doses of the foundational therapies, the ACEI or ARB, the beta blocker, and the aldosterone antagonist, plus diuretics as needed.
So just for symptoms, not survival.
Exactly. The definitive evidence came from the large DIG trials, Digitalis Investigation Group. These trials clearly showed that while digoxin did reduce the rate of hospitalizations for worsening heart failure, so it did provide some symptomatic benefit and reduced decompensation episodes, it offered absolutely no decrease in overall mortality compared to placebo.
No survival benefit. That's the bottom line. So is there any situation where digoxin is still considered truly the preferred or best drug?
Yes, there is one major indication where it still holds a primary role. That's when the patient has heart failure, specifically HFrEF, complicated by concurrent atrial fibrillation, AF, with a rapid ventricular response.
Oh, the combination.
Right. In patients with both HFrEF and AFib needing control of their ventricular heart rate, digoxin is often considered one of the best choices, sometimes even preferred over beta blockers initially if the patient is borderline hypertensive. Its ability to slow conduction through the AV node via vagomimetic and direct actions is very effective at reducing the number of rapid atrial impulses that reach the ventricle, thereby controlling the heart rate without further depressing contractility significantly, unlike high-dose beta blockers might. So in that specific combination, HFrEF plus AFib needing rate control, digoxin remains a very important tool.
Okay, for our deep dive to be truly comprehensive, we need to cover the agents used in more acute situations, like decompensated heart failure or those representing the cutting edge of disease modification. Let's start with the older guard for acute support. Sympathomimetic inotropic drugs.
Right, these are the drugs you reach for when the pump is acutely failing and you need rapid, powerful support. The main players are dopamine and dobutamine. They work primarily through stimulating beta-adrenergic receptors, and dopamine also hits D1 receptors, leading to increased contractility and heart rate. They provide prompt, potent hemodynamic support, which can be especially critical when the patient presents with acute pump failure and low blood pressure, cardiogenic shock.
But they're just for the short term, right?
Absolutely. They are purely for temporary stabilization, like a bridge. Their benefits are short-lasting, patients can develop tolerance to their effects, and they carry a significant potential for cardiotoxicity and increasing myocardial oxygen demand, which can be harmful long-term. They have absolutely zero role in the chronic long-term management of heart failure.
Okay. What about the so-called inodilators, the phosphodiesterase 3 inhibitors, like milrinone? They seem interesting because they hit two targets: increasing contractility and dilating blood vessels. Why did they ultimately fail the test for long-term use?
Yeah, milrinone and its predecessor inamamrinone, which had issues with thrombocytopenia, work by inhibiting phosphodiesterase 3, PDE3. This enzyme normally breaks down cyclic AMP, CMP inside cells. By inhibiting PDE3, you get an increase in intracellular CAMP levels in both the heart muscle and vascular smooth muscle.
And CAMP does.
In the heart, increased CAMP-A leads to positive and inotropy, stronger contraction. In the blood vessels, it leads to relaxation and vasodilation. So they are indeed inadilators. They provide excellent hemodynamic improvement in the short term, reducing preload and afterload while boosting cardiac output.
Sounds good, so what went wrong?
The problem arose when they were tested in oral formulations for chronic, long-term maintenance therapy. The results, particularly from the PROMISE trial with milrinone, were disastrous. Patients receiving the oral PDE3 inhibitor actually had increased mortality compared to those receiving placebo.
Increased mortality, why?
The exact reasons are debated, but it's likely related to the inherent toxicity of chronically elevated intracellular CMP levels. This can increase the risk of arrhythmias, particularly ventricular arrhythmias, and sudden cardiac death, and might also accelerate disease progression in other ways. Consequently, the use of PDE3 inhibitors like milrinone is now strictly restricted to short-term IV therapy for patients with severe refractory heart failure, often as a bridge to transplant or other definitive therapy.
Another cautionary tale. Now, a more unique mechanism comes from levosimendan. It's also considered an inodilator, but it seems to avoid the main drawback of classic inotropes like digoxin or the PDE inhibitors regarding calcium overload.
That's correct. Levosimendan has a novel primary mechanism. It's a calcium sensitizer. It achieves its positive inotropic effect mainly by binding to cardiac troponin C and sensitizing it to the effects of calcium without actually increasing the intracellular calcium concentration.
So it makes the existing calcium work harder.
Essentially, yes. It enhances the interaction between calcium and the contractile proteins. This is thought to be advantageous because it might increase contractility without significantly increasing myocardial oxygen consumption or the risk of calcium overload-induced arrhythmias, unlike traditional positive inotropes. It also has a secondary action as a PDE3 inhibitor, contributing to its vasodilator effects.
Where is it typically used?
It's primarily used, mainly outside the U.S. currently, for the short-term treatment of acutely decompensated severe chronic heart failure, particularly when beta blockers might be contributing to the low output state. One clinical challenge with levosimendan is that it has a long-lasting active metabolite, which can sometimes lead to prolonged hypotension after the infusion is stopped.
Okay, interesting mechanism. Now, we absolutely have to analyze what many consider the ultimate evolutionary leap in medical therapy for HFrEF, the combination drug, sacubitril/valsartan. This seems like more than just blocking a single harmful pathway.
It really represents a paradigm shift within the paradigm shift, if you will. It's the first approved drug in a class called ARNI's angiotensin receptor neprilysin inhibitors. It combines two components, valsartan, which is a standard ARB, blocking the destructive effects of angiotensin II via the AT1 receptor.
Okay, the RAS blockade part we know. What does sacubitril do?
Sacubitril is the novel component. It's a prodrug that gets converted to an active metabolite, which inhibits an enzyme called neprilysin. Neprilysin is the enzyme primarily responsible for breaking down several beneficial vasoactive peptides in the body, most importantly, the natriuretic peptides ANP and BNP.
The body's own protective hormones.
Exactly. By inhibiting neprilysin, sacubitril prevents the breakdown of these beneficial peptides. This leads to increased levels of ANP and BNP, which promote vasodilation, natriuresis, sodium excretion, diuresis, water excretion, and also have anti-proliferative and anti-fibrotic effects. They actively counter the effects of the RAAS and sympathetic systems.
So with sacubitril/valsartan, we are finally, simultaneously, attacking the major destructive pathway, RAS, and actively boosting the body's own protective counter-regulatory mechanisms.
Precisely. It's a dual mechanism of action. And the results from the pivotal PARADIGE-HF trial were stunning. Compared directly against enalapril, the gold standard ACE inhibitor at the time, sacubitril/valsartan demonstrated a further significant reduction in the combined endpoint of cardiovascular death and hospitalization for heart failure in patients with symptomatic HFrEF. It proved that this two-pronged approach, blocking the bad and enhancing the good, is superior to just blocking the bad alone with standard RAS inhibition. It's now a cornerstone therapy for eligible patients with HFrEF.
Truly groundbreaking. We should also touch on ivabradine. What's its highly specific niche in heart failure?
Ivabradine has a very focused mechanism. It's a pure heart rate lowering agent. It works by specifically inhibiting the if-funny current in the sinoatrial SA node, which is the natural pacemaker of the heart.
So it just slows the pacemaker.
Yes, it slows the rate of diastolic depolarization in the SA node, leading to a dose-dependent reduction in heart rate without affecting myocardial contractility, blood pressure, or cardiac conduction elsewhere in the heart. Its indication is quite specific. For patients with stable, symptomatic chronic HFrEF who are already on optimal medical therapy, including a beta blocker at the maximum tolerated dose, or who have a contraindication to beta blockers, who are in normal sinus rhythm, and who still have a resting heart rate greater than 70 beats per minute.
Why is just slowing the heart rate beneficial?
By slowing the heart rate, ivabradine allows more time for ventricular filling during diastole, which can improve stroke volume, especially in hearts that are rate dependent. It also reduces myocardial oxygen demand. Trials like SHIFT showed that adding ivabradine in this specific patient population reduced the risk of cardiovascular death or hospitalization for worsening heart failure.
Okay, a very targeted therapy. Finally, let's briefly mention nasiratide and tolvaptan for the really tough refractory cases.
Right, these are more specialized agents. Nasiratide is synthetic brain natriuretic peptide, BNP. Given as an intravenous infusion, it's a potent vasodilator and promotes natriuresis, rapidly reducing cardiac filling pressures. It's sometimes used for short-term symptomatic improvement in patients with acutely decompensated heart failure who remain congested despite aggressive diuretics. However, studies haven't shown a mortality benefit, and there were concerns about potential adverse effects on kidney function and mortality, so its use has become quite limited.
And tolvaptan.
Tolvaptan is different. It's an oral vasopressin V2 receptor antagonist. Vasopressin, also called antidiuretic hormone, ADH, normally promotes water retention by the kidneys. By blocking its V2 receptor, tolvaptan promotes aphoresis, the excretion of free water, without significant loss of electrolytes like sodium or potassium. Its main use in advanced heart failure is to help manage severe fluid overload or hyponatremia, low sodium levels, that is resistant to conventional diuretics. Again, like nasiratide, it can provide short-term symptomatic or biochemical improvement, but studies haven't demonstrated a clear long-term prognostic benefit in terms of mortality or major heart failure events. #tag outro. So if we synthesize this entire deep dive, the central, absolutely crucial modern realization is that heart failure, particularly HFrEF, is not just a simple mechanical problem of a weak pump needing a stronger contraction booster that was the old digoxin model.
Right.
Instead, we now understand it as a complex, progressive hormonal and cellular disease fundamentally driven by the body's own maladaptive, ultimately destructive compensatory mechanisms, primarily the hyperactive renin-angiotensin-aldosterone system and the chronic sympathetic overdrive. This profound shift in understanding mandated the therapeutic shift away from agents focused purely on contractility, like digoxin, towards life-prolonging, remodeling, reversing neurohumoral antagonists. The ACE inhibitors, the ARBs, the beta blockers, and the aldosterone antagonists, they became the foundation because they target the root causes of progression.
And when you look back at digoxin through this modern lens, this lens of mastery we've tried to achieve today, its limitations become glaringly obvious, don't they? That incredibly tightrope walk of its low therapeutic index, the constant risk of toxicity, it's fundamentally linked to the fact that both its beneficial effects and its toxic effects share the exact same root cause, that manipulation, whether controlled or uncontrolled, of myocardial calcium loading. That inherent risk profile, coupled with its complete inability to stop or revert the underlying disease progression, really sealed its fate as a secondary add-on agent once better life-saving options became available. We've really aimed for professional mastery today over cardiac glycosides and the remarkable evolution of heart failure therapy. We noted how, even with the gold standard neurohumoral blockers, the ACE/ARBs, beta blockers, aldosterone antagonists, the disease often still finds ways to progress. The body's protective systems, like the natriuretic peptides, seem to get overwhelmed, and the destructive systems, like RAS, are often only partially blocked or find ways to escape.
Which brings us perfectly to a final provocative thought for you, the professional listener, to really consider as you take this knowledge forward. We saw the sacubitril/valsartan combination launch that innovative two-pronged pharmacological attack, simultaneously blocking the destructive angiotensin system while actively enhancing the body's own protective natriuretic peptide system. Does this powerful realization that perhaps the ultimate therapeutic leap involves not just blocking the bad pathways, but actively enhancing the good protective ones, represent the future model for pharmacological interventions across medicine?
Yeah, think about it. What other current diseases where the pathology is driven by a similar kind of vicious imbalance, maybe autoimmune diseases, maybe neurodegenerative disorders, or just waiting for a similar multi-system therapeutic strategy?
Mm.
One that doesn't just neutralize the failure pathways, but actively supercharges the body's own resilience pathways.
That's the kind of forward thinking that pushes medicine ahead.
Absolutely. That is the crucial connection professionals must make when thinking about the future. We've done the deep dive. Thanks for joining us, and we'll catch you next time.